I will share again. Now, now the audiogram is seen on the screen.
Yeah, can you put the presentation in the presentation mode, please? In other words, try to, it's usually at the bottom right-hand side from PowerPoint.
Yeah.
Yeah.
Yeah, I'm in presentation mode right now.
Yeah. Okay, go ahead.
Now the pure tone is shown on the screen.
Yes, the
Okay.
audiometry slide is on the screen.
Okay, so so as clear, there is no airborne gap on the operated ear on the left ear, and it is obvious that there is mixed hearing loss with the significant airborne gap of non-operated ear on the right side. Tympanometry was normal impedance curve on both sides. And so accordingly, we proceed to VNG, video nystagmographic testing. As from this slide, we can see that there is right beating nystagmus. And for VNG findings, it is right beating spontaneous nystagmus that follow Alexander's law. This gives an idea that these patients may have vestibular hypofunction on the operated left ear. Positioning test was negative. I did positioning. I did the Dexol pike and I did supine roll and repeat them 2-3 times. All the test was negative. There was normal smooth pursuits, normal saccadic eye movement, and normal optokinetic test. That means normal neurotological test. And from these findings, as unilateral vestibular hypofunction is being suspected, I was so interested of caloric test, but unfortunately, the patient refused caloric testing because she has an idea that this test will bring like very severe nystagmus, and she don't want to go through this testing. So I proceed to head impulse test. Interestingly, with the head impulse test, there was, sorry, Professor? I can't hear you, Professor.
Yeah, the slides are not moving. Are you going through slides?
Yes, I'm going through the slides.
And we only still at the, now you're going to the, okay, the VNG finding, okay.
These are the VNG findings. And now the head impulse is clear on the screen.
Yes, we see that. Okay.
So interestingly, there was overt saccades on the lateral semicircular canal on the operated ear. This is the overt saccades. Again, this is the overt saccades. Again, this is the overt saccades. But surprisingly, there was also overt saccades on the non-operated ear, on the lateral canal of the non-operated ear. As we can see in this slide, and also on this slide, and also on this slide. So accordingly, there was a normal gain of the lateral semicircular canals on both sides with overt saccades also on both sides. The gain of the posterior and the anterior semicircular canal was normal without any saccades. So these findings may give rise also to suspicion of like bilateral vestibulopathy. So we proceed with the dynamic visual acuity testing that shows significant reduced visual acuity in the horizontal and vertical planes. There was no recent change of hearing noticed by the patient, and there was no history of dizziness or vertigo before the last 3 months. For the long period of otosclerosis, the balance situation of the patient was normal. At that point, I discovered that I'm facing a complicated case. It is not a straightforward vestibular patient, and it needs a lot of thinking. It needs a lot of more sophisticated investigations. And here at that point, I just want to explain the situation of what we are doing in Iraq, that we are doing all these tests in private sections. So, and there is no established medical insurance system in Iraq. So patients have to pay all the tests, whatever the test that we do, whatever the test that I will recommend for imaging, for example, for CT, the patient should pay for it. So our strategy as a clinicians in Iraq is to find the diagnosis with the least possible investigations. And also, real speaking, that we are so busy in our clinic. So we have limitation of time, we have a lot of patients. So we know we want to solve the problem of as much of the patient as we can. We don't want to go for further useless, let's say, useless investigations. So at that point, I was thinking what to do. Shall I do VEMS for the operated air, as shown by Tamar, Tramon, Tani, Ital, that a successful surgery will lead to closure of airborne gap and will let air conduction waves to be shown, to be identified? Or should I go to a CT scanning of that patient for imaging, or should I proceed to perform electrocochleography for this patient? In fact, all these questions rise in my mind, and then for all these factors that I already discussed, I decided to do nothing, to send patient home and to just start fluoride treatment to the patient, to give sodium fluoride to the patient, and to start home exercises, vestibular rehabilitation by home exercises. This is another challenge for neuro-otological practice in Iraq, that we have a lack of personnel. We don't have vestibular rehabilitation personnel. We don't have physiotherapists. So for nowadays we have VR system in our center, but before, for the last 5 years, I was only depends on simple home exercise that I learned the patient to do at home, and I follow the patient with. So I decided to start fluoride treatment because I discovered that for the period of like 30 to 40 years of history of otosclerosis, no one prescribed fluoride medication to this patient. And this is again another mistake of our otologists, that they usually neglect fluoride medication for patients with otosclerosis. So I decided to do so. I decided to start fluoride medication, and I decided to go for home exercises as a rehabilitation, and to follow the patient by phone call because she's far from Baghdad, from our center, and to do like phone conversation with her like 1 time per week. To follow up the case. And at that time, I will give a chance to myself to do some review of literatures, to decide what things that I should do next to this patient. So when I did a review of literature, I find that causes of late vertigo after stapedectomy, most of the cases is due to benign positional vertigo, benign paroxysmal positional vertigo. And of course, this is not the case, not our case, because I did positioning testing many times carefully, and I repeat with negative results. Perilymphatic fistula is another possibility, as mentioned by the literatures, and in our case there is no fluctuation of hearing level, and there is no any development of a new airborne gap by pure audiometry. So this is also, let's say, it is far from possibility of our case. Again, there is some possibility of depressed foot plates. Also, there is no any change of situation of hearing. There is no any change there is no development of any like middle ear problem by tympano or by airborne gap, new airborne gap, and also what's called endolymphatic hydrops. Endolymphatic hydrops was also a possibility as mentioned by the literature. Now, What is the causes of late vertigo in case of autosclerosis? Because all of us knows that autosclerosis is a bilateral disease, and still we have autosclerosis in the right ear, non-operated ear. Secondary endolymphatic eye drop, secondary to autosclerosis, is very well established by the literature. That is as shown by Yoon et al. And also shown by Anita Pollack, that development of sclerotic foci on the endolymphatic sac may lead to secondary endolymphatic eye drops and picture similar to Meniere's disease. And also it is shown by the literature what is called bilateral vestibulopathy, as shown by Sir Teach Yati Chair, which show a case of bilateral vestibulopathy due to autosclerosis. So I reviewed these literatures, and I decided if the patient get no benefit to go for to do electrocoagulography and CT scan imaging for the temporal bone. The good news, fortunately, that the patient was vertigo-free for 2 months of fluoride therapy and home exercises. Yes, sorry, Professor.
Haider, sorry, can you please make me a co-host, because there are people who want to get in, and you probably cannot see them on your screen. So hover over my picture and make me a co-host. That's all what you need to do.
Yes.
Okay, thank you. And if you see a name flashing on your screen, just hit admit.
Yes.
Okay.
Yes.
Sorry about interruption.
Sorry. So the patients, fortunately, the good news that the patient was vertigo-free for 2 months on fluoride therapy and home exercises. From these findings, I will keep the provisional diagnosis of that case to you for discussion. But for me, I think it was early stage unilateral or bilateral vestibular hypofunction that respond to fluoride therapy and physiotherapy, and the problem is already solved with only simple these measures. That's all for my case, and I'm happy to open discussion about it, about any question, any form of discussion. I'm ready to discuss it with you. Thank you very much. Sorry, Professor. Yes. Yes.
Yeah. Thank you. Can you make me a host, actually, not co-host, please? Okay. Yeah, same thing, so that I can.
Yes. Yes.
Yeah. All right. Thank you. This is a very nice paper. We see these patients quite often. So let us see if we have questions here. Would everybody please post your questions on the chat box? Waiting for some questions. I think you made a very good point about the absence of insurance companies to cover vestibular testing, and you should try to make your diagnosis based on the most informative tests. And in this patient, obviously, it was a bit of a challenge, but you thought about it the right way, and the patient improved on fluoride therapy. We don't actually use fluoride therapy in the United States. We use bisphosphonates in patients with advanced autosclerosis. In this situation, I probably would have liked to look at the CT scan to see if there is any evidence of autosclerosis on the CT scans. But she tolerated the fluoride therapy and did here in terms of hearing. Hello?